Okay, well, let me go back. Welcome, everyone, and thank you for joining. My name is Trixie Thibodeau, health educator for Atlantic Health Community Health. Today, our webinar is Treating Diabetes Holistically, and it's being presented by Dr. Jeffrey Feldman. But before we begin, I have a few announcements. The webinar is being recorded and will be shared in its entirety on our website. All participants are muted. If you have a question, please use the Q&A for the questions or the chat for comments. We will try to get through all questions at the end of the presentation. Take care of your health. Go to the physician or hospital and get your annual screenings. For more information, you can visit us at atlantichealth.org/yourhealth. Now I'm going to turn it over to Dr. Feldman. And Dr. Feldman, just let me know when you want me to change slides.
Yeah, you can. Next slide.
Okay.
So you can click on that.
I can click on that now. Okay.
Yes. And I'll talk while that's going on. Oh, I can't talk. Go on. You can click on that.
Okay. And let's see.
My father was a dentist. He did have some friends that were physicians. From early on, I sort of knew I wanted to be a physician. I found my way in early on with a group of nephrologists. We had transplants, so it was an easy decision. I was fortunate to train and get wonderful training. I've changed my emphasis to be more office-based and work. While I do work with people that need renal replacement therapy, transplants, or dialysis, my emphasis is in preventative care. We have outcomes that show that if they're placed on certain medicines, they do better than other patients and will not end up on dialysis, and it prevents cardiovascular complications. So you're looking for a doctor that works with multi-specialty people, not just focuses on the kidneys. We take care of the whole body, and it's more preventative than anything else.
Okay.
So that basically is my approach to our patients. When I was trained in both the Bronx and then especially in Brooklyn, my mentors who were concerned about kidney disease were more preventative, even though I trained in the 70s and 80s when everybody was doing dialysis. We did focus on prevention, and the big one was diabetes. Next slide. So before we begin, I want to thank everybody for attending. This is a good day. You're staying safe from the ice, which I hope you all avoid, which the ice is actually as bad as diabetes because it can really, if you fall, really hurt you. So be careful today. And I want to thank Trixie. She spent a lot of time with me preparing this, and I hope you can all benefit from this. So diabetes is a complex metabolic process. We have focused on how people, particularly with develop type 2 diabetes, that is over many years, obesity, and also the pancreas, the effects of the pancreas, and it is unable to produce enough insulin over many years. At the same time, the insulin is not functioning 100% because of metabolic changes related to obesity and diabetes in our internal organs. And we call this insulin resistance. However, for many years, we focused on traditional markers of blood sugar, and particularly the A1C. So when you go to your provider, they ask you about your blood sugars. They do an A1C. The A1C is a marker of the average blood sugar over 8 to 10 weeks. And diabetes is a chronic process. In addition to its effects on the sugar, with people that are overweight or obese, they develop high blood sugar, abnormal lipids, and the insulin, as I just alluded to, is not effective. So there are many patients, as you'll see, elderly that develop diabetes, and with obesity, diabetes is developing at an earlier age in patients 30 and 40 years old. And diabetes is a combination, as I just explained to you, of a metabolic process that impairs the beta cell in the pancreas, which produces insulin, to decrease the production because of the insulin resistance. And it plays a major role in not only in type 2 diabetes, but the metabolic effects, which we will review in the next few minutes. Next slide. So, because we had a lot of medicines in the recent past that lower blood sugar, whether it be insulin, sulfonylureas, metformin, then the onset with what we call DPP-4 inhibitors, dipeptide 4 inhibitors, we concentrated on a surrogate marker for drug approval. Surrogate marker means you lower the blood sugar, you lower the A1C, and then the people from the FDA were happy and they approved this drug. So it's not really it is a marker of how the sugar is doing, but there are more things going on behind them. And the new paradigm is since 2008 with our newest studies, where we're mandated to look at the effects of drugs on outcomes, and we'll review those in the next few minutes. The approach is a multi-organ approach using medications that not only control blood sugar, but protect from the chronic complications. And we break the chronic complications into microvascular disease. So we know diabetes causes a lot of amputations, neuropathy with pain in the feet, sores that can lead to infection and loss of an extremity or toes. It causes changes in the eyes, both diabetic retinopathy and what we call macular edema. It's the leading cause of blindness. And we always focused on macrovascular complications, and that's cardiovascular disease, strokes, peripheral vascular disease, which is atherosclerosis superimposed on what we call microvascular complications, neuropathy and angiopathy leading to infection and loss of limbs. So they do sort of overlap. One of the newer things that we've seen a complication is heart failure. So that's in addition, when we think of macrovascular complications, you think of strokes, heart attacks, peripheral vascular disease, and people going into the hospital with chest pain syndromes and needing angioplasties or bypass. So macrovascular now includes the interaction of diabetes with chronic complications and heart failure. Next slide. So people that develop diabetes, and now they're developing it younger related to obesity, but as you age, and we want to all age graciously, and for senior citizens, unfortunately, most academic doctors used to use the 65 and older. Well, most of them now are these academic doctors who do these studies are now 65. So while we use 65 and older, it's actually patient, our patient population is aging. So we also look at 75 years old. So people that develop diabetes in their 50s and have diabetes for many years, it's a complex interaction of genetics. If you go back into the family history, a lot of patients have strong family history for type 2 diabetes. Their lifestyle, and what we mean, their choices for different foods. In addition, we now looking at sleep patterns. We know patients need to get better sleep and exercise, and in addition to the aging factor. So each patient that develops diabetes are at risk for their own complications related to what we consider pathophysiology. That means what's happening in the body, how the clinical presentation is, and the rate of progression over time. So we now know that between the ages of 65 and 79, 33% of people will be told they're now diabetic. And so that's lifestyle changes, additional weight gain, genetics, and again, poor choices. And basically 50% of adults will not even know they have diabetes, but will go into the hospital with a condition like heart failure or chest pain and be told, do you know you're diabetic? And that's on the basis of the A1C being greater than 6.5 or 7. So this is a silent disease. It's a silent disease for many years, and it causes the number one morbidity and mortality in our senior citizens. That is cardiovascular complications. Next slide. So this is why you can't look at diabetes as just the blood sugar alteration. It is what we call an ominous octet. It affects all the organs in the body. And by the way, this concept is now over 12 years old. So I'm not telling you anything that most physicians don't know. The person that brought this to our attention in foremost is a prominent researcher in Texas. Fortunately, he's from Brooklyn, New York. This is a 12-year-old concept. So you look at diabetes as impaired insulin secretion from what on the far left, the pancreas, but it has a detrimental effect on other organs like the gut. On the right there where it says impaired lipolysis, that's what we call your adipose tissue, or the in layman's term, fat. You accumulate fat in the wrong places, in the liver, around the kidney, around the heart, and around the intestines. And these produces hormones that causes huge problems for us. The kidney, we thought, was affected by diabetes, but the kidney also participates in diabetes in that there are processes which, when the blood sugar goes up, the kidney will super function and reclaim all the blood sugar. So your blood sugar is increased because the kidney will reabsorb blood sugar and not let it escape into the organ or into the urine. And the kidney also makes sugar, just like the liver makes sugar. And if you don't eat, and there's what the process is called gluconeogenesis, that the liver and the kidney turn on to produce blood, to produce glucose, to protect your brain from hypoglycemia. At the center of all of this is the brain, which you can see in the bottom. And again, the liver is deeply involved as both producing extra blood sugar, or HGP, which is gluconeogenesis. And what that is telling you is the liver additionally makes lipids, and it stores lipids. So the liver is very deeply involved. And the last thing is, why do people develop insulin resistance? That is because multiple tissues, including the muscles, for some reason, don't utilize the insulin appropriately. We call that insulin resistance. Next slide. So this again is the same picture, and this is just a picture, and we'll get back to this, of how we treat diabetes more appropriately when we use targeted medications to what we call the pathophysiology, the things I just went over. Next slide. So the management of diabetes, when you go to your doctor, he'll ask you how your blood sugar is. He'll do an A1C, and he may tell you, well, if your blood sugar is better, you'll have less macrovascular complications like kidney disease, eye disease, neuropathy, vascular disease leading to amputations. You'll have less macrovascular complications related to heart disease, peripheral vascular disease, strokes, and heart failure. And you should live longer. So complications are tied in to poorly controlled diabetes over many years. And as you're all aware, if you are diabetic, in addition to your primary care doctor, you are seeing multiple specialists, including ophthalmologists, podiatrists. You may see endocrinologists and cardiologists, and you get different messages from each of them. Next slide. So what I'm trying to lay out for you is diabetes is what we call a chronic process. It begins early on. And we call that pre-diabetes, whether your blood sugar is high when you fast or after you eat, or people now use the A1C, which again is the blood sugar over 8 to 9 weeks, the average blood sugar. So diabetes starts pre-diabetes, and all those internal malfunctions that I showed you in the various organs occur. And another famous diabetologist, again in Texas, called this the ticking clock theory. So you're feeling fine, you don't feel you have any problems, and 10 or 14 years later, you may find out that, go to the ER for various cardiovascular complications or an infection, which is more infections in diabetes. Some people develop cancer with diabetes, and all of a sudden you're being told you're diabetic. Well, that just didn't occur. It started 10 years before. So we try and ask all of our patients, no matter what their risk is, to have yearly physicals, blood work, and part of that would be an A1C, a blood sugar. And if you have what we call pre-diabetes and you're gaining weight, then we look at prevention. And prevention is, basically good choices for food, lifestyle, exercise, and now we throw in sleep. And then additionally, you can decrease the risk of patients developing pre-diabetes to diabetes, which occurs in 30 to 40% of people, by using an agent, metformin, which is cheap, it's relatively safe, with few side effects if used appropriately, and it does slow the process of patients developing frank diabetes, and it actually has some outcomes to improve and reduce the risk of those complications we address. So, but additionally, when you get an examination, and hopefully once a year if you're in good health, but you need to ask about your risk factors: hypertension, your lipids. If you're a smoker, you need to develop a smoke endings program. If you're gaining weight, you need a lifestyle modification. If you're having sleep disorder, we need to deal with that. So obesity, and another condition which is easily discernible in the liver, which increases the risk of cardiovascular and diabetes, as this diabetes develops from pre-diabetes, is what we call non-alcoholic fatty liver disease. For a simple thing, as you gain weight, there's excess calories. The storage of the excess calories overwhelms the natural body's system, and the calories and nutrition go to what we call ectopic places. And ectopic means it doesn't belong there. And one of the places we see is in the liver. So we can see fatty liver, and you can get a hint of this just from routine blood tests. The lipids are important. Diabetes not only affects your bad cholesterol, it raises your what we call your fats or your triglycerides, and it can lower your good cholesterol. Next slide. And the other thing is your blood pressure. And from want of a simple term, as we age, high blood pressure increases, and we want your blood pressure to be as close to 130 and 80 over most time. People develop chronic kidney disease when they get blood work. We measure something called an eGFR, which is an estimation of your kidney function and filtration, which comes with all the blood work. But more importantly, people can have normal filtration and function, and diabetes can affect in 40 to 50% of people some albumin, or what we call microalbumin. That means your kidney is spilling a little bit of protein. The only way you know that is to get a urine analysis and see if there's protein or a urinary albumin to creatinine ratio. And unfortunately, when we screen big data sets, even in diabetics, that is, diabetics are recommended, particularly if they have hypertension, to have urine analysis and have urine screened for albumin to creatinine ratio twice a year. When we go into large databases, even across the most eminent healthcare systems, including Atlantic, only 30% of people are getting these on a regular basis. We now look at sleep patterns, obstructing sleep apnea, and also I'd be remiss if we didn't talk about smoking. Fortunately, in New Jersey, the rate of smoking is much less than the international average and the national average, but it's still quite high and it is a risk enhancer, not only for heart disease, but vascular disease, and makes things worse. So this is the concept of the ticking clock over many years, where a disease that's silent, a metabolic and nutritional disease, evolves into diabetes, can affect multiple organs, including the liver, the heart, the kidneys, the eyes, the lower extremities, and you show up, lo and behold, in the ER with the complication, and you're told you're diabetic. That didn't happen in over a few months. It happened over probably 8 to 10 years. Next slide. So let's look at why we need to focus in on everything I just told you with a good clinical exam once or twice a year with your doctors. So we're going to look at A1C, and as all the studies suggested, a good control of your blood sugar, or A1C less than 7, should reduce the risk of eye disease, retinopathy, lower extremity disease, neuropathy, diabetic kidney disease. And so it follows that if the A1C is controlled, your complications would be less. Therefore, when you go to see your doctor, they ask you about your blood sugar, they ask you about your A1C. So the assumption is better control of the A1C, no matter which drugs you use, or if you're fortunate enough to control your A1C with diet and exercise, your A1C, if it's less than 7, the predetermined level, you should have less microvascular, macrovascular, heart problems, vascular problems over time. So let's look at that next slide. So here's why our paradigm has to change. So these are very large studies that were done over many years. They're old studies. You know, this UK PDS study is probably 20 years old. Advance is, and the VA study and Accord, probably over 10 years. And so they compare large groups of patients, and they told the doctors, just get some of the patients are randomized to an A1C of 7 or 6.3 or 6.9 or 6.4. The rest are just given usual treatment, and their A1Cs are, as you can see, 7.9, 7, 8.4, and 7.5. You then look at the outcomes, or when the people that have more intense treatment, that is, their A1C is 7 or less, do they have less eye problems, kidney problems, lower extremity neuropathy problems, less kidney failure, less heart disease, less strokes? The answer is no. So as long as your A1C is around 7, you're still at risk for macrovascular and microvascular complications, even though your A1C is at goal. Next slide. So why is this? Why is the edict that we've been focused on up until about 5 years ago, why is this a problem? Why does type 2 diabetes associated with longer high morbidity and earlier mortality, and also poor quality of life for most people? So we can see that controlling blood sugar, or A1C, has not been a successful goal in improving outcomes. So many of the older medications that we've used and studied had adverse side effects like weight gain and hypoglycemia, which are associated with poor outcomes. So recent studies, so in 2008, the FDA had some concerns about cardiovascular studies with a class of medications called TZDs, which are wonderful medications, but one of them seemed to produce more cardiovascular events, and that was called rosiglitazone or Avandia. And for a while, the FDA did a lot of studies and put some warnings that if patients are on Avandia, they have a higher risk of cardiovascular outcomes, and therefore don't use it. So they mandated large studies with the newer agents. And so most of our newer agents, whether they be insulin, They be a class of medicine called SGL2 inhibitors, which we'll look at a little bit. A class called GLP-1 RAs or insulins. They all have to have outcome studies for 2 to 5 years to show that they do not produce cardiovascular events more so than just the classic medications like sulfonylurea, metformins, and a few other medications. And lo and behold, in 2015, there was a medication that showed not only was it not causing cardiovascular outcomes, but it caused less cardiovascular death and less heart failure. And this opened up a whole new era, 2015 to current, and there's still studies with drugs that we can use that produce less renal failure, less heart failure. And when I say less heart failure, that's admissions to the hospital. And particularly during COVID, we do not want patients in the hospital, but patients come to the hospital, they get admitted for heart failure, and 20 to 30% in the next, some even as in 4 weeks, but most by 6 months, get readmitted to the hospital for recurrent heart failure. One class of agents that we use instead of insulin produces less strokes. They all produce less cardiovascular events. And we're now mandated to say, okay, I see you and I put you on these newer drugs and I tell you you're not going to get admitted, your kidneys will improve. And you say, yeah, okay. But now I can tell you your quality of life is going to improve. With these medicines, you'll be able to do more, you'll have more energy. And again, you'll have less admissions to the hospital. So the quality of life and exercise tolerance is another recent way we study these medications. So I hope, in summary, I've convinced you that if you just focus on A1C and you're older and you've had diabetes for more than 10 years, you're taking a path in the wrong direction. Next slide. So that means that we have to approach our patients with cardiometabolic syndrome, which is what diabetes is. It's a complication of everything I just explained, holistic approach, not just looking at A1C, but looking at the whole body. And that brings us to the use of medications for prevention, which is new. Most doctors wait till you get to the hospital and they do a few procedures on you. And then they say, well, you got to quit smoking. You got to follow your diet. You got to exercise. You got to take this medicine to lower your cholesterol. You take this medicine to lower your blood pressure. So we don't have to wait for that. And if we're seeing patients with diabetes and we do proper screening with the use of proper medications and lifestyle changes, we can reverse some of the long-term effects of the diabetes on the kidneys and the heart and the vasculature. And additionally, you get improvement in the quality of life and a reduction in complications. So with that, we're now going to focus on the holistic approach. Obesity. Over the recent 5 years or 6 years, ask yourself, are you gaining weight? Have you had a evaluation with different lab abnormalities? And, like it's just a simple comprehensive metabolic profile, which is a picture of various abnormalities for the kidney and the liver. And is your liver test not normal? And are you at risk for fatty infiltration into the liver? And fatty infiltration into the liver accelerates the onset of diabetes, but it also accelerates cardiovascular events. Are your lipids being addressed appropriately? So basically, if you have a heart attack, your cardiologist may say, take this statin, and it's proven to reduce cardiovascular events. But we now have guidelines. So we look at not only what your bad cholesterol is, and if you've had an event or you've had a catheterization, our team looks at a bad cholesterol, not 100, not even 70, but now down to 50. What is your good cholesterol? What's your triglycerides? If they're elevated and the triglycerides and your good cholesterol is low, we have another medicine that can reduce cardiovascular events related to a holistic product, high-grade fish oil, and with outcomes. So in addition to a statin or other medicines to lower your bad cholesterol, we use prescription grade fish oil. We want to get your blood pressure down to any less than 130 systolic. We want to monitor your kidney function. Is it getting worse over a period of time? Is what we call your serum creatinine slowly rising? Have you had a urine for albumin to creatinine ratio? Is your sleep habits poor? The minimum requirement for good sleep, good nutrition, so you feel well and you can take care of yourself is 7 hours of sleep. If people are sleeping 9 hours, that's just as bad as getting 4 hours. So we want people to sleep between 7 and 8 hours. Are you at risk for obstructive sleep apnea? Does your partner say you're snoring? Do you wake up poorly in the morning? During the day, do you feel tired and you can't do all your activities? And of course, smoking, when we have good programs to help people to quit smoking. Next slide. So I'm sorry this doesn't show. This is from the ADA patient-centered goals. So let me just read this to you. It's our new program is what's called pillars or foundations of care, and they intersect the various risk factors that I just addressed. So we look at the pillars. So the first pillar is lifestyle, and that means diet and exercise and sleep. While the second pillar is glycemic control, we have to use appropriate medicines to get there. Blood pressure management is the second and third pillar, with lipid management and appropriate medications to get to the goal we need for diabetic management. So we're going to take a patient-centered approach in adults that are gaining weight or obese, and they could develop or are developing diabetes. We're going to talk about programs for weight loss, nutritional evaluation with our nutritionists for prevention of weight gains, the appropriate medications that will not cause weight gain or cause hypoglycemia to reduce the progression of diabetes and abnormal blood sugars, attention to the cardiovascular risk factors, attention to comorbidities like I addressed, non-alcoholic fatty liver disease, obstructive sleep apnea, and the kidneys, both the filtration and is there protein in the urine. Next slide. So in particular, this is more complicated as our patients are getting older and making unhealthy choices and unhealthy lifestyles. And we don't like to use the word increased fat or call people fat because that's derogatory. Sometimes the medicines are causing people to gain weight. And I've discovered that in my practice, using the appropriate medicine with appropriate diet and exercise, we can get people to lose some weight. And we look at what's called adiposity. And ectopic means, like I addressed before, the extra calories and fats are going into the liver, in and around the kidneys, in and around the heart, and in and around the intestines. And they create inflammation and chronic changes, leading to further weight gain and vascular abnormalities that make the hypoglycemia worse and accelerate biological aging. So as we all age, we want to use the correct term. We want to age graciously. We want our biological age and our chronological age to be the same. Some people can be 40 and their biological age is 70. That's not good. And we can actually determine that by various studies, but we want to start early to change and address the changes in body composition related to poor choices with poor nutrition, sedentary lifestyle, a lot of medicines, and we'll talk about that shortly. And just as you can, it's never too late to quit smoking. After you have smoking cessation for 5 years, there are a lot of improvements in both the risk of heart disease, the risk for cancer. So it's never too late to adopt healthy eating habits along with proper exercise and proper sleep. So we have a lot of disagreements, a lot about nutrition or different things. Excuse me, sorry. Sorry about that. But one thing we all agree on, the minimum amount of exercise is 140 minutes a week. You can do that in blocks of 10 minutes. So we recommend 10 minutes twice a day, 6 or 7 days a week, and you'll get to that goal, and it can be nothing more than walking. Aging and obesity are associated, as I've shown you, with metabolic dysregulation, and inflammation, particularly if you're gaining weight. The burden increases over time, not only because the blood sugars are high, the obesity causes secondary changes, but once you start developing microvascular changes, and kidney disease and macrovascular disease related to atherosclerosis and the effects of diabetes, the comorbidities get worse and you're at high risk for events. Next slide. So one of the things that I don't know if you picked up on that as a physician, we're always embarrassed by is not responding to the patient's complaints. And, the fact is, as we all get older, we have functional disability. It's harder to exercise because of muscle loss. People have multiple comorbidities, hypertension, obesity, coronary disease. Some people have unfortunately had a stroke, they have vascular disease. But these all lead to poor quality of life and then premature death. So one of the things that is really a problem is that as we talked about these comorbidities, diabetes, hypertension, dyslipidemia, there's polypharmacy. So the patient who comes to me may end up telling me, but I'm on 8 or 10 different medications. And that's true because they got 3 or 4 different complications, whether it be with diabetes plus hypertension, diabetes with abnormal lipids, obesity. And some people need help with cigarette smoking. And so this leads to polypharmacy. And as people are obese with diabetes and kidney disease, they may be on 3 or 4 antihypertensives to get their pressure down. They also may be on 2 or 3 different lipid drugs. So, and 3 or 4 medications for their diabetes. So polypharmacy is real, but if it's used correctly, it will improve the outcomes. If patients have cognitive impairment or anxiety, depression, it becomes more difficult to manage them with the use of all these medications, asking them to follow a diet and everything. So polypharmacy is real. And we have at Atlantic Health a care coordination team who provides not only care for answering questions, reviewing your medications, explaining things better than maybe the physician will, but also helping with behavioral health, with depression and anxiety. Additionally, as we age, unfortunately, there's more incontinence, people high risk of falls and pain. So we have to individualize this and approach the patient and to set goals to decrease risk factor control. Next slide. And so this is my final slide. It goes back to show you that diabetes, and again, this is an old concept. It involves the ominous octet involving not only the pancreas, which we always thought was the seed, but intestinal changes, the effects of obesity on the right there, the effects of the liver on number 7, the effects on the muscle, The kidney is deeply involved. The heart is really involved, and the brain is at the center of all this. And these are our newer medications, which are called SGLT2 inhibitors. We use a lot of metformin and glucagon-like peptide antagonists. So with these current guideline-directed therapy, number 4, 6 is a staple, and also the glucagon peptide antagonist, we don't have to use as much insulin as sulfonylureas. We reduce the risk of people developing hypoglycemia and weight gain, and they're cardioprotective. These medications have studies showing they protect the kidney, they protect the heart, they reduce the fatty infiltration into the liver. But these are just several medicines, and it gets into the antihypertensives and the medicines for lipid disorders. And the one class of medicines I left out is that we use a lot, particularly if you do have vascular complication, antiplatelet drugs, drugs for anticoagulation. And all the drugs we're using now, most of them, I should say the majority of them, have outcomes for improved outcomes to reduce events. And with reduced events, particularly heart failure, there's better quality of life and better outcomes. So with that, I'm going to stop. If people have questions, I'm more than have time to answer your questions.
Okay, we'll give a moment or two. We have one question so far and get started with that one. The question is, what can I do to better control my blood sugar when it is due to the side effect of another medication? My A1C has gone from 6.1 to 6.8 since beginning of the new medication for cholesterol.
So there is a adage out there that statin therapy makes your cholesterol worse. So the FDA has studied this, and in Europe it's been studied. There's a label you can read if you are obese and you're not following your diet and you're pre-diabetic and you go on an agent like Lipitor, your blood sugar may go up a few points and your A1C may go up. It doesn't go from 6.1 to 6.8. It usually goes up from 6.1 to 6.3. And again, if you looked at those 4 studies, having an A1C of 6.8 is perfectly acceptable because you don't have any worse outcomes. If the ADA for many years has a guideline which says all diabetics, no matter what their LDL cholesterol between the age of 45 and 75, should be on a moderately intense statin or a high intense statin, because that reduces the risk of heart attacks and strokes. So you're looking at numbers. And again, my approach to diabetes, which I try to impart to you, is not looking at numbers, particularly not A1C, because if you reduce your on a moderate intensity statin, you get a 12% reduction of the risk of a heart attack or a stroke. On a high intensity statin, which is basically 40 of Lipitor or 20 milligrams of generic Questor or Rovastatin, you get a 20% reduction in stroke. So I don't know about you. I don't want to particularly have a stroke. I'm not big on having a heart attack either, particularly if you have chest pain, you're going to wind up in the ER. And even though we're in a low COVID situation, our hospitals give us a gift. Still, it's the gift of COVID coming out of there. So we're very good at COVID right now. Our numbers are good, but there's still a higher risk. So again, you take the whole approach. A1C hasn't prevented heart attacks, I can tell you that. It particularly hasn't prevented kidney disease or heart failure. So to have and again, I don't think the A1C went from 6.1 to 6.8 from a statin. It usually goes up 0.2 or 0.3.
Okay, next question is, does being diabetic cause vertigo?
In truth, and in that, the answer is if you've had a stroke involving posterior, um, the posterior circulation in what we call the cerebellum, the balance center. Yeah, you can get chronic vertigo, but most vertigo is what we call, and you don't going to like what we call it because it's benign positional vertigo. If you have bad vertigo, I know it's not benign, but that's what they call it. So there's a high incidence of vertigo unrelated to diabetes. So vertigo occurs in a certain percentage of the population. Diabetes occurs in about 1/3, and I didn't get into this. Currently, in adults between the ages of 21 and 35, excuse me, 21 and 75, diabetes occurs in 30% of our population. It's even higher. And so 35 million people in the United States have diabetes. A lot of them don't know they have it. And even twice that number have prediabetes and are at risk for developing diabetes. So vertigo can be common. So you have two conditions that are common. Are they related to one another? The only thing that would relate it to would be a stroke. So it's true, and unrelated.
Okay, thank you. And one more question. What is your opinion of osmemic?
Of what? Oh,
I'm sorry, Ozempic.
So the answer is I love it, but this is a non-branded talk, and I work for a large healthcare organization, so we're not supposed to promote one drug over another. So that belongs to a class of drugs called GLP-1 RAs, glucagon receptor agonists, and it's a medication. There are several of them on the market, of which that particular medication that you mentioned is one of them that has large outcomes trials, and their outcome trials are available in the public domain, or if you Google it. So I can't promote one over the other, but I will answer the question generically. So over the years, when patients' blood sugars have gone too high, their A1Cs are over 8, we've put patients and we convince patients to go on insulin. Insulin over many years, and I'm talking 8 to 10 years, causes people to gain weight. It causes people to reabsorb a lot of fluids and sodium. The blood pressure can go high. And we now have these agents which have been available for about 10 years with outcome studies that actually it's a pharmacological drug. It's a natural protein or hormone that's in our guts that the body uses. It's bioengineered to have a long half-life, so you only have to inject either daily or once weekly with the newer ones. They lower the blood sugar better than insulin. They protect, the outcome studies show they protect the heart, and they cause good weight loss as you have what we call early satiety. They affect the brain and the gut, so you eat less and you have less weight loss. I've been able to take people off of insulin and they continue to lose weight. These drugs are so effective. I've had several people lose too much weight that I had to stop them. So we monitor them closely. They're very, very good. They do have side effects and they have to be used appropriately. So the class of drugs, which are called incretins, GLP-1 RAs, have been able to replace insulin with better diabetic control. And again, they have outcome studies to protect your heart. Additionally, there's less strokes on several of these studies, and they appear to produce positive effects on your kidneys. So it's a grand slam. Oh, and one other thing is they do have a effect, particularly if you lose weight, if you follow a diet, you exercise, if you are at risk for what's called non-alcoholic fatty liver disease, which can cause problems unto itself, they reduce the amount of fat infiltration into the liver. So they are positive drugs that should be used. And again, they're all equally effective if used appropriately.
Okay, one more question came through before we end. What do you recommend to a pre-diabetic and skinny person in order to gain weight without raising blood sugar?
I would, so the first thing is a healthy heart diet, which you can Google, with just increasing your calories. But you got to be careful with that, and you monitor your, obviously your blood sugar A1C. But that's a tricky question. 80 type 2, how old if the patient's in their 50s or 60s, type they would be classified most likely as a type 2 diabetic. And 85% of our type 2 diabetics have weight gain, overweight or obesity, but a small percentage have they're at their goal weight, their BMIs, which BMI is what we use, the weight over the height meters squared, and the BMI is usually in about 10% normal, but it also depends on ethnicity. So people from Asia or the Asian Pacific, they may have a normal BMI, and the waist circumference is normal if they're from, again, Asian Pacific or Asian, and they are at risk for diabetes because they have insulin resistance related to their genetic background. But if the answer is if they are not from the Asian Pacific, and you need some help with that, you may want to seek the help of a nutritionist.
Okay, thank you.
But one thing I want to say in closing, thank you all. So while that presentation that I just gave you is my view of the world, my view of the world to taking care and getting better outcomes is a team approach. And I did mention our collaborative care with Atlantic Health, who I'm very grateful for the help, just like Trixie. She's part of some Atlantic Care. That's a secret that we don't know, most of us don't know exists. So I thank you, Trixie, for everything. But we have a collaborative care team at Atlantic Health, who your physicians, if you are an Atlantic Health Care patient, have access to, that provides questions and answers for not only just medical questions, but pharmacy, and also behavioral health for stress management. So we have a team approach, and we also have community healthcare workers who can help you get some of the medicines. The other risk factor for these newer medicines, which are wonderful and are preventative, like the medicine that the person asked me about, they're very expensive. And while your insurance may say they'll pay for it, the copay may be $300. So, we do have resources to help you get to where we need to do. So it's a team approach, because this is, it's very, very difficult. And we want people to have, particularly in their seniors, to have better outcomes, stay out of the hospital, and be able to enjoy their life, what we call quality of care life. So thank you.
Okay, so this concludes our webinar. Thank you for joining us, and a special thank you to Dr. Feldman for dedicating your time and expertise today. If you have any additional questions or comments, please send us an email to communityhealth@atlantichealth.org, or you can give us a call at 1-844-472-8499. Thank you, everyone, and have a great day.